Everyone, thank you for joining our Health and Action work group today. This will feature a presentation by Neeley and Shelly Schoen of Michigan Medicine, and I look forward to facilitating this work group today. Thank you for being here. So as I stated, today's Health and Action work group will feature Neeley and Shelly Schoen of Michigan Medicine. Neeley is a project manager at Michigan Medicine, focusing on population health, quality, and care management in the ambulatory setting. In this role, she is responsible for developing, implementing, and maintaining transitions of care pathways and alternative sites of care with an aim to prevent avoidable admissions and reduce preventable readmissions. Michelle is passionate about ensuring that patients receive high-quality coordinated care. Shelly Schoen is the panel manager supervisor at Michigan Medicine. In this role, she is responsible for overseeing the day-to-day operations of the panel manager team, who provides outreach to patients to facilitate gaps in care closure, transitions of care support, and management of rapid access scheduling. Shelly believes in holistic patient care and takes pride in leading a dedicated team who is passionate about supporting patients. Thank you, Michelle and Shelly, for being here today. Before you begin your presentation, I have a few housekeeping items to review. So first, this session is being recorded. The slides and the recording will be shared with all attendees following the work group. Next, we will be monitoring the chat throughout the presentation, so feel free to add questions there. We'll also have some designated time at the end of Michelle and Shelly's presentation for an open Q&A and discussion. And then lastly, your feedback is very important to us. If you could please complete the post work group survey in a link that will be provided in the chat at the end of the work group, as well as in the follow-up email. That would be greatly appreciated. And then as a reminder for hospitals participating in P4P who would like to receive credit for this work group, this survey is mandatory, and please note the one hospital that you are attending on behalf of so that you can appropriately receive credit for this work group. So without further ado, I will pass it over to Michelle and Shelly for their presentation. Thank you so much for being here today. I'm going to stop sharing my screen now.
Shelly is going to be pulling up our slides. While she does that, I just wanted to mention that we do not have any financial conflicts of interest to disclose. That's one of our slides, but it's a boring one, so we can probably just breeze through that one. Shelly, do you want to go to slide 3? Okay. So thank you for having us. We're here to talk about the rapid access pathways that we developed here at Michigan Medicine. What was the problem we were trying to solve? We were faced with high ED census, as I'm sure a lot of other healthcare organizations face. But there was patients that could go home if they had close follow-up in place, but our ED did not have any awareness or any insight into what that outpatient access would look like, and if patients could get an appointment in a timely manner, which led to the emergency department often admitting patients to either an observation or inpatient status that otherwise could have gone home had we been able to secure that follow-up prior to discharge. So how do we address this? We developed a pathway, which we refer to as rapid access pathways, that ensures a safe discharge home with that follow-up in place prior to the discharge. So the patient goes home knowing their follow-up plan, and they have that appointment already scheduled for them prior to being discharged. This helps us mitigate an admission for patients that could have that safe discharge home. Next slide. So this is just a list of the current pathways that we have live. Currently, we'll talk about our implementation approach and how we got there, but this is just a quick overview of the current pathways that we have active today. ADTU stands for it wouldn't fit on the shape, but it stands for Ambulatory Diagnostic Treatment Unit. It is kind of like a step in between the emergency room and primary care, kind of like an urgent care, if you will, which Michigan Medicine does not have, but this service typically provides fluids for patients who just need fluids. So that's what that is. And then we have some future pathways currently in conversations for consideration, which are our podiatry clinics and ophthalmology. So we're currently discussing the needs for those and developing the build. All right, next slide. So how do we go about doing this? It took a lot of great brain power from our ambulatory and ED leaders that came together and tried to talk about what the problem was and how we were going to approach solving the problem. We analyzed a lot of different data to understand our areas of opportunities. Where do we need to hone these rapid access pathways in? Who needed them? What types of services did these patients need? So we looked at a lot of data, specifically looking at really short lengths of stay and what those conditions were to formulate who do we need to talk to and what kinds of service does this patient need. Had they had an appointment in GI, we would have been able to save an admission, those kinds of conversations. So we started with the data to see where the opportunities were. Then we engaged with the specialty leadership on the ambulatory side to develop a pathway for rapid access. And each specialty approaches this a little bit differently in how they secure that rapid access slot. We didn't want to use access or to create a block on a schedule that could potentially go unused, especially since in the beginning, we didn't really understand the volume. Like we had the historical data and what we could maybe anticipate, but we didn't really know how often or when these were going to be used. And so we didn't want to further our access issues by creating a slot that could potentially go unused. So like I said, each area kind of handles this a little bit differently. Some areas have a generic provider schedule. So it doesn't go on a particular provider. They have a generic grid, and then somebody through like a rotation schedule will cover that appointment. Some people have it in a mid session, like between an AM and PM session. They have a block in the middle. Or in some areas, we allow for any open or urgent slots to be scheduled. And because we are a PCMH designated primary care clinic, we have to have 30% urgent availability at the beginning of each day. So for primary care, we do allow any open or unblocked slots to allow scheduling. So we have to get creative, depending on the area, kind of dictates how we do this. But like I said, we really did not want to create further access issues by holding slots. So we do it uniquely depending on the specialty's needs. We also designated schedulers for this initiative, and Shelly's going to talk a little bit more about that. But we knew that we would have to have a 24/7 process to allow for real-time responses. And that's because the ED needed to know. They needed to know, can this patient be seen before they were able to discharge the patient. The ED is open 24/7, so we had to have a 24/7 response method. So this work really kicked off in September 2020. We convened a steering committee. There were some existing rapid access pathways, but none of them were streamlined or standardized. They were kind of all doing different things, which led to a lot of confusion and a lot of scheduling issues. In December of 2020, we launched our first 2 streamlined pathways, which were primary care and GI. And then over the next 6 months, we did continuous PDCA cycles, made changes, and really try to understand what was going on. We did initially have some low uptick to referrals, and that ended up being to re-educate the ED on these available pathways and gain that relationship and foster trust between the ED and the ambulatory side, which kind of had always operated pretty siloed from each other. And so that was our first 6 months is really doing a lot of that continuous improvement. And then in July of 2022, we launched additional pathways, so all the other ones that you saw. And then from then on, we're in kind of a sustainment mode with now just starting to have new discussions of additional pathways that we're considering for implementation. I'll turn it over to Shelly.
Yeah, so this is where we started our workflow. So our workflow starts at the emergency room with their providers determining that rapid access would be an appropriate option for the patient. The provider then will place a rapid access referral within our Epic system. That referral gets routed to a work queue, and it also will page the scheduler. And then the scheduler will then review the referral and search for an appointment within the requested time frame and report back to the ED provider. If there is an available appointment, the patient is then discharged home with the visit information on their discharge paperwork. If for some reason we are unable to schedule an appointment, the ED provider would then just need to establish another care plan based on the patient's needs prior to discharge, or admit the patient, whichever is the appropriate care plan. This slide is regarding our staffing model. So we have the centralized panel management team that I supervise that manages the rapid access referrals. So during the normal business hours, this work is part of their daily workload expectations. And then for the nighttime and weekend referrals, we have somebody who is on call that will manage those referrals as they come in. And in an effort to reduce the number of on-call hours, we did get a little creative with non-traditional working hours that would roll into the evening.
So some barriers and lessons we learned throughout this process was that having real-time data helped us make decisions. And for example, understanding our access and how often we were scheduling these appointments really led to some of those continuous improvement changes that I was mentioning earlier. We had predicted how much access we would need based on the historical data, but we found that actually it really didn't align, and that people were really hungry for these pathways. So initially we did have a lot of access issues, but without the ability to monitor and track that real time, we would have not been able to quickly make changes to our workflows and pivot to other options. So that was something that we had learned, was the ability to track this in real time was critical for continuous improvement. We also met frequently with ED and ambulatory leadership. We were meeting weekly in the beginning, and then we changed that to monthly, and now we're on a quarterly basis as like a check-in point. But those frequent conversations and meetings are really helpful to understand what was going on from the ED's perspective, from ambulatory's perspective, what was happening with scheduling, what was happening with the patients, were these appropriate referrals or not? And so we had a lot of meetings in the beginning to really understand what was going on and make changes as necessary.
We did run into some issues with the interest in the 24/7 expectations. So there was some hesitancy in the beginning with that on-call expectations. We originally started with a call center supporting the daytime hours, but as the contact center got busier and their call volumes increased, it became difficult to have the representatives be off live calls to manage those referrals. So that was when we moved it to the centralized panel manager team to support the referrals. And we have done that ever since. Then we did also learn that using the secure chat within Epic was much more successful than calling the ED with the scheduling outcomes. The secure chat option through Epic is also available on the provider's phones. So we didn't have to worry about whether there was somebody standing next to the phone to take our call on the ED, as you can imagine, extremely busy. So that alleviated that barrier. Not saying that the ED providers are, if they're in a rapid access situation or a rapid response situation, that we might miss them, but it was definitely proved to be more successful. And then depending on the area where our staff lives, pagers proved to be a little unreliable. So we worked with our IT team to be able to have the pages then go to the staff's cell phones instead of just the pagers. So it does do both to ensure that we don't miss anything. So that was a hurdle we had to overcome, but it was successful.
And then some outcomes. This first section here is looking at the appointments that were scheduled per the fiscal year. And our first fiscal year was only 6 months, but and just the two pathways, and kind of alluded to earlier, we did have some we did have to try to re-communicate a couple of times and get the ED used to this being an available option for their patients. And also our ED has ever-changing providers as we're a teaching institution, so learners are coming in and out all the time. And so we developed some materials. In the first, during our first fiscal year, we had 23 referrals that were scheduled. And then in FY 22, we had 360. FY 23 went down just a little bit to 342. And then current fiscal year to date, with 3 months left in the fiscal year, we have 251. So we're anticipating kind of being in that mid 300 range once the fiscal year is completely done. And then the days to appointment, these are from our program start. So the days to appointment and then the admissions within 30 days are all data from program start in 2020. So the days to the appointment from when the referral was placed to when the appointment was completed was 2.71. If we hone in on just the more recent times, like fiscal year to date, we're actually seeing a closer to a 2 median days to appointment range. And someone did ask in the chat, which I think was a helpful question that we probably should have already mentioned, is that what is the time frame for these appointments? Most of our pathways are within 3 days of discharge, or from that referral. We need to see the patient within 3 calendar days. But there are some referrals or some pathways that the specialty has said it's actually 10 days would be clinically appropriate for that patient. So we kind of align to whatever the specialty thinks is most appropriate for the patient, but in general, it's typically 3 days. Low risk PE, for example, is one that they said, it could be more appropriate for the patient to be seen further out. But as long as they're seen within 10 days, it could save an admission. So anyways, that is our days to appointment median, including those, the variation and that expected time frame. And then admissions within 30 days, there was 678 completed appointments and 31 admissions, which is a 4.57%, which would kind of indicate to us that most of these referrals were appropriate and should not have otherwise been admitted. So I think that's all in terms of data we have to share. And then I think our next slide is just a question slide. So I see some questions coming into the chat. Christy, are you going to moderate those, or how do you want to address?
Yeah, I'd be happy to moderate them. Thank you for sharing that awesome work. So you addressed the first question, but the second question that we have for you is from Ashley Rosa. Could the ED schedule the appointments?
Yeah, so in theory, yes. We have some scope issues with like I said before, our ED and ambulatory area, they're pretty siloed, and our schedules are on the ambulatory side, and they feel much ownership over their schedules. And so there's a scope issue there. So technically speaking, probably. Operationally speaking, not this time for us.
Awesome. So the next question that we have is from Christy DeYoung. Did you assess which diseases or conditions were most likely to require unnecessary admission and then create a pathway for them? For example, COPD or CHF?
Yeah, so in some of them, we just looked at what are the conditions that are requiring these really short length of stays, and then what the specialty to understand what would they need. So for example, AFib was one that we were often seeing being admitted to observation status, and then they were being discharged. So we went and talked to them about that, and they had said, oh, we just need an appointment with electrophysiology. And so we set up that pathway specific to that condition. In general, we do it at the specialty level, but if there is a need for a condition specific pathway, we have developed that to make sure that the patients have what they need to be able to go home safely. But in general, it is typically at the specialty level, not the condition.
Great. And I actually do have a follow-up question to that. When you were first analyzing the data, did you have a specific time frame that you were looking at? Like how far did you go back when you kind of first looking at all of the data?
Yeah, so I would have to go back and look at it. I want to say we looked at like 18 months to 2 years worth of data. And because we started this in 2020, it was, during COVID. We just anything that was 2020 we disregarded and then looked back pre-COVID. I'm sure now if you're doing it, you would have to like make considerations for that COVID time period if that was included in the data that you're reviewing. But we just excluded it because we were only 6 months into the year at that point.
That definitely makes sense. And then that brings up one other question I had since you brought up COVID. I did see kind of you convening the steering committee in September of 2020. So I was really interested to see or learn about how COVID may have impacted any of your implementation approaches. If so, how, if not, just curious.
That's a good question. I think we were able to use COVID kind of to an advantage, to say we really need to make sure that we have space and capacity in our hospital for patients that need care the most during this time. And so that helped with the buy-in and the engagement. We didn't actually study if it made any impact on like the hospital census or anything like that. But that storyline or that narrative did help. And that was really truly kind of what launched us to do this during COVID. It had been talked about for many, many years. And, we're still talking about, well, how do we prevent the patient from even getting to the ED in the first place? But the issue was we had really high ED census in general. And then during COVID, we wanted to make sure that the patients that needed care could get care the most.
Definitely makes sense. Thank you. Looks like we have a few other questions in the chat. Another from Christy. For outpatient scheduling, do you have a centralized scheduling system or does each specialty practice handle their own scheduling?
Shelly, you want to answer that?
Yeah, so that's where the centralized panel management team comes in. So as those referrals come into the work queue and we get paged for those, the centralized team that I support does all of those scheduling. So I think we only have one pathway that we kind of split some of the efforts depending on time of day. But generally the panel managers, they at least facilitate getting that appointment scheduled for all of the pathways.
Yeah, and just to add on, we built it for those that are alive on an Epic system. We built decision trees. So it takes out a lot of the questions of what department do I need to use, what visit type do I need to use, and those kinds of things, and also the time frame in which we allow rapid access. So they launch a decision tree based on where the referral is placed to. It's a single referral. They just pick what specialty, the ED picks what specialty they want to refer to, and based on that response is what launches the decision tree to show solutions to the schedulers. So just you guys behind the scenes.
Yeah, and that did expedite the time of scheduling. So you're not like, going to this department and that department and pulling up their individual grid. So that did help with response time to the ED.
Wonderful. Thank you. Our next question is from Jennifer Anderson. Which pathway was the hardest to establish and what were the barriers?
I personally would say the GI pathway was the hardest to establish, and not in a way of like we had issues with buy-in or engagement. We had a lot of engagement. We had a really hard time on figuring out how to accommodate rapid access for this clinic. They have some unique scheduling that occurs in GI, and they have fellows and they have some methods for some scheduling rules, I guess I should say, for if a patient is already established versus a new patient, and a lot of complexity that our schedulers wouldn't really be able to understand. And so one of the ways that we addressed that was we said during the day, we'll call you. If it's during business hours, we'll call you and you can place the patient wherever you think is most appropriate. But if it's after hours, then we have to have some sort of way to schedule. And so during after hours, we do a generic provider schedule. They can still move the patient to whoever they think is the most appropriate provider to see the patient, but just during the same time slot that we scheduled it in. So because of their unique scheduling and also, you know, they have a lot of subspecialties within GI and trying to figure out who's the most appropriate provider. That was probably the most challenging. They are also one of our heaviest hitters. And so initially it was trying to figure out appropriateness for the referrals that came in. And so we had a lot of reviews happening on the ED side, and on the GI side, we had great engagement from that group to look at the referrals and make sure they were appropriate, and then figure out how to create some inclusion and exclusion criteria based on the feedback that we had received.
Wonderful, thank you. We have one other question in the chat from Jenna. Who did you recruit to participate in the initial steering committee? Any specialties or roles that were really key to engage early?
So initially it was like our capacity management group on the ED side, and our medical director of the emergency department. And then on the ambulatory side, it was the director of business operations and myself as the project manager. Initially, we all reviewed the data and had those discussions about which areas we thought we could start with and make the largest impact on. And then from there, we kind of broke up into subgroups. So like Belkis, who is our director of business operations, and I would meet with a specialty, formulate the plan of how we would accomplish this, and then do everything we would need to do, you know, getting rapid access visit types and updating the referral to make sure this was an available pathway, training the panel managers. I would connect with Shelly and those kinds of activities, and then go back to the ED, let them know the new pathway was going, update their educational materials, and then launch the new pathway. So it was kind of broken up into subsections depending on what area we were focusing on. But I think ED and ambulatory representation was definitely key.
Definitely a very collaborative effort. We do have a few more questions that trickled in. Another one from Jennifer. Which pathway had the greatest impact to reducing readmissions or reducing admissions?
So cardiology, specifically our AFib, and gastroenterology are the two ones that I think have our biggest impact on mitigating unnecessary admissions.
Great. And then a question from Scott Gothier. Are all the specialties within the U of M system, or are there any outside specialties? I'm thinking about hospitals that do not have all the specialties listed.
That's a great question. These are all specific to Michigan Medicine, to this health system, but we have worked with St. Joe's to offer rapid access for Michigan Medicine patients. So not exactly what you're asking. These appointments are all within our system, but we had extended some partnership to St. Joe's to also try to use some of these pathways for patients, our patients that they were seeing, to help them with their, you know, census as well.
Great. And then we have a question from Helen Silkworth. Did you see a reduction in your readmission rates for COPD and heart failure patients with this process?
So readmissions were not something that we looked at or measuring as it relates to the ED. And pulmonology is actually a really underutilized pathway. So my guess would be, if we looked at it, probably no. We initially created some of these pathways as a specialty team-based care initiative through, it was a program through Blue Cross Blue Shield. And so pulmonology was one of those areas that we created the pathway to meet the criteria for the specialty team-based care initiatives. We still have it live, but it is underutilized. And I think that's the feedback that I had gotten from our emergency department, was that typically those patients are either fine and they can go home, or they're really sick and they need to be admitted. So there's really not a lot of in between for that population.
Wonderful, thank you. So that looks like it's all the questions in the chat. Does anyone else have any other questions for Michelle or Shelly?
I have a quick one just about, you mentioned sustainability, and I'm just wondering what that you think that looks like in terms of the continuation of your staffing model, and whether that's kind of, is that, I assume that's not grant funded, or what does that kind of plan look like for you all?
Yeah, so I'll let Shelly talk a little bit about the model and how we accomplish that from like the financial perspective. We did have to at first it was a pilot, and then it turned into more operations, and so we did have to find people that actually wanted to do this work. The carrot being that they get the overtime or off hours premiums during this time. We didn't want to staff it 24/7 at a full, pay rate, because that would have just been unsustainable. For now, I think it's sustainable, but as we talk about adding new clinics, which are currently under discussion, we're just have to continue to monitor. Shelly, did you want to add to that about the staffing model, sustainability?
Yeah, I think that having the panel manager staff kind of share the workload during the week, it helps them still maintain, their day-to-day responsibilities, and also manage these pages more than the contact center. Like I had mentioned before, you never know, the live calls coming in, and then you have these pages that are just randomly coming in as well. That was a little less sustainable as they got busier. It has been working really well with the panel managers, and I think that we can sustain that during normal business hours. And like I had indicated earlier, to kind of offload from the financial standpoint of the need for additional on-call and overtime wages, having one panel manager who kind of works a shifted routine schedule, Monday through Friday, it goes into, 8 p.m. into the evening. So that's less on-call hours overnight that we would need to cover that and have those additional wages, because that is still part of that person's expectation and their normal workload as well.
Wonderful, thank you. I have one final question for you both that kind of goes back to one of the barriers you were mentioning about, provider education about the program, and it being difficult because of turnover and new providers always coming into the ED and whatnot. Can you tell us a little bit about the materials that you developed, or one thing that stood out to you as being super helpful in the process of educating everyone and making sure everyone was on the same page?
Yeah, so I have a kind of a 3-part answer to this. One was like a 1-page material, which I think was really helpful to post in the rooms and whatnot. The challenge with that is that it had to be changed out every time there was new information, every time we launched a new pathway. But having a quick reference on, so like the 1-pager I created had what is rapid access? How do you refer to it? So it was like, put this referral in, answer these questions, and then what do you expect? And so it talked about the communication feedback loop, and it was just a quick reference guide for them to know what rapid access was and how did they do it and what can they expect. But like I said, the challenge was making sure that they had the most updated version. The second thing that we did, which I think has a lot less traction, but I'm gonna let you know because we have it as an option. In our referral in the in Epic, there is a link to a ED page, and that is an alternative to admissions. And then there's a list of the rapid access pathways, inclusion and exclusion criteria, and more information about the pathways. Like I said, probably low utilization on people actually going to that click and linking and going to find other information, but it is there. The third thing that I think is probably the most helpful is using the referral questions to guide them into making a decision about, is this an appropriate referral? For ones that we had that are limited to conditions, for example, dermatology is only able to do rapid access on set conditions. Once they select dermatology, it cascades to a question that says, what are you referring for? And then in like parentheses or something like that, I'm trying to recall off the top of my head, so it might not be 100% accurate, but it says something along the lines of rapid access is limited to dermatology for these conditions only. And then it has speed buttons for them to pick whether I don't remember the conditions, but it will condition A, B, C, and D. And then that helps guide their decision. If, oh, the condition I want to refer for is not listed, I can't refer, and so they don't. So I think try to embed some of that decision making into the referral process is probably the most beneficial, but also there are areas that don't want to limit the referrals by condition. So kind of it depends. I think a combination of the cascading questions within the referral and the one-page material are probably the most helpful things that we developed, but yeah.
Awesome. Very helpful. Thank you. Does anyone have any final questions for Michelle or Shelly? Thank you so much for sharing this awesome work. We can include Michelle and Shelly's email addresses if that's okay with you both. If there's any follow-up questions, we'll be sure to include that so you can follow up with them accordingly. Wonderful. If there's no other questions, I can go ahead and bring up our slides to conclude the work group today. Thank you again, Michelle and Shelly, for sharing this work.
Thank you. Thanks for having us.
So I did just want to highlight the remaining work groups in our Health in Action work group series. As a reminder, to receive the 0.25 points for the work group series, you must attend all 4 work groups and participate in at least 80% of the session. At July 9th, Health in Action work group, there will be a presentation by the Opioid Prescribing Engagement Network, and that will feature their ongoing initiatives. And then the October 8th work group will feature Michigan Medicine's Hospital Care at Home program. So those are the 2 final ones for this year. I did want to also review some upcoming work groups. So on April 25th, we will have a sepsis work group that will feature Oakland Hospital's sepsis algorithm and provider documentation tips. And then in the beginning of May, we will have a preoperative testing work group that is going to feature Munson Healthcare, Cadillac Hospitals, preoperative testing strategies, and lessons learned. In addition to these work groups, I did want to highlight that we do have our spring collaborative wide meeting, which is an in-person event that will occur on May 10th in Midland, Michigan. The registration was recently sent for that, so we definitely encourage everyone to join if you're able. If you didn't receive that registration information, please send us an email. We'll be sure that you get that accordingly. So with that, thank you so much for attending the work group today. I did see that Jana did just post the link to the survey in the chat. So I'll give everyone a few minutes to grab that link so you can complete the work group survey. And then we will conclude shortly. But thank you again so much for your presentation, Michelle and Shelly. Thank you everyone for coming, and we hope to see you soon.